direction do I have to take her to do the scapular Y, the oblique shoulder?
Away.
Yeah, AP away. AP away. Uh-oh, one of my markers is missing.
Oh. Which
Oh,
one?
maybe not.
So
Got
on
it
your
in
back?
another pocket.
Then it would be your right one that's missing.
My
but
left
on my
one's
back.
missing.
Left one?
It should have the little BB markers on it.
There we go.
Yeah. Move these around, the one disappearing too.
Do they have your name on it?
No, they're KIG. I don't even know who they belong to. But I think they sent me some samples or something. They're still mine.
Still yours. I was gonna say, otherwise you'll start having your name out there
I
on
know.
your radiographs. You'll be like,
Yeah,
what?
right.
I don't remember doing this.
Okay, so I'm going to show you the left shoulder in the AP because it's just easier for me to show you. Now I'm going to keep this back from 40 inches just so you have more visual area to see, okay? But normally we have to bring the tube into 40 for this, so we should be right here, okay? I'm just going to push it back so you can see what I'm doing. Okay, so she's protecting her shoulder. This is a trauma, remember? So all we're going to do is put our hand in the medial and lateral border of the scapula and then rotate her 45 degrees with her feet too. Okay, come back towards me just a little bit, this way. Okay, what we end up doing, now I'm going to have her move her arm for a minute so you can see where I'm centering. But we end up bisecting right through the scapula right here. But with her arm in the rested position to support the trauma, look where it ends up centering. Right over the surgical neck of the shoulder. You see that? So when you're doing the trauma, you basically just center at the surgical neck. As long as your fingers are perpendicular to the IR, then you've got enough rotation here. And then I'm going to collimate down to the part because you don't need all this extra light out here causing primary radiation scatter. I'm going to check my positioning. Here's the top of the scapular blade. Here's her inferior border, so my CR should be right in the middle. See that? And I should be able to see my fingers. See the shadow of my fingers?
Mm-hmm.
So I know that my top to bottom collimation is adequate. Okay? Some of you could, well, no, you might not be able to see from over there. So anyway. And then you just want to collimate in a little closer. So this would probably be a good place for my marker. Okay? Now I'm going to skip ahead for a minute to show you the lateral scapula. Because it's the same body position, we just have to do one change. And what is that?
Put the arm.
Get the arm. So up and out of the way. So when she brings her arm up, I can feel the lateral border. I can feel the medial border. I just want to make sure my fingers are going to be in alignment. So now what we're basically doing is we're skimming through the scapula. And you're seeing the Y view here. Where'd my scapula go? I have a
Oh,
bone.
right there. Behind my. There we go.
Poor skeleton. So basically, we're looking at this. This is the other shoulder. Okay? Okay. Now, if we're going to do the PA projection, go ahead and face the board. I'm going to show you her right shoulder since it's closest to me. Do you want him to be the patient? Okay.
Okay.
Yeah.
She said she was cold.
Oh.
It's just like it got a certain point in the day and now I'm cold.
So now what direction do I need to turn her?
Towards.
Towards. So again, I'm just going to place my hand at the sides of her scapula and then turn her towards the IR. Now you'll see when I do that, see how this is the medial border of the scapula and I never get to be the patient. I want to be the patient one time. This is the medial border. You want the CR to skim just anterior to that. Okay, so lean against this. Because notice how she's kind of keeps little está borracho today, I think. They had a little lunch. But you know, that's one thing. If your patient has been medicated or has been drinking, you want to probably do this on the table because one of the problems with doing it upright is you may not be able to get them to hold still. Okay. All right, so here's the medial border of the scapula. The CR is going to skim right through it and lean her against here so she stops swaying back and forth. And again, I'm going to collimate side to side. Okay? Okay. Now Now, if we're going to do the scapular Y, what do I need to do with her hand?
Put it in the back.
Yeah, so I either one, reach her up and across,
Across.
which now you can really feel the scapula, and have her lean close here. Move over just a little bit. Okay, so now, because when you do that, it does pull the scapula around a little bit, so you need to reposition just a little. Or she can do it with her arm behind her, the arrest or West Point view. And when they do that, you can really feel the scapula. So this is easier to do it to palpate the scapula, but the problem is you're going to have the humeral head over the top part of the scapula, and so you might miss that anatomy. But if it's just for the lateral of the body of the scapula here, this would work as well, because you're going to have the humerus here and the body here. Well seen.
So the scapular Y can only be done PA, right? Or can it be done?
It can be done AP or PA.
Okay.
Now, remember I told you in theory this would be better because it's closer to the IR, but in clinical practice, the day I was at a clinic where they did like 10 of these in a row, every single one of the APs was fine, and every time they tried a PA, it didn't. And then see, as we turn the patient, see how we've now created the Y right here? Wait, let me close on that one. See the Y? The body, and then the Y up here with the acromion and the coracoid. See how superimposed on top of itself? When you bring the arm up in a way, the reason you're not seeing the space here is because it's screwed into the thorax. But in a person, you'd have a space right here. Okay? So in the PA, see how the CR enters right anterior to the medial border of the scapula here. And again, you can see how you can see the Y here and the medial and lateral border are superimposed. Okay? Alrighty. Yeah. And for the clavicle, it kind of doesn't. Yeah, I'm getting warm. What? Not that warm. That would be like, oh, now I'm really warm.
No, she's freezing.
I know. But I'm moving around and she's not so much, so.
So many people
Okay, so
here.
the top to bottom collimation is about 5 inches, and then the side to side can be 12 inches. Okay, so for the clavicle, you want to make sure you have the head of the clavicle at the SC joint, so the light's going to be just beyond the mid-coronal, mid-sagittal plane, MSP, here. And then I want to find where the clavicle articulates here at the AC joint. So the light's going to be just beyond the clavicle head here and just beyond the AC joint here. I'm going to scoot her over just a little bit so she's centered. And then the CR ends up where?
Mid-clavicle.
Yeah, right at the mid shaft. So remember there's kind of an S curve here to the clavicle, so you just kind of palpate. Now don't do it hard because they probably have a fracture. That's why they have an X-ray. Okay, so this was the AP. Of course we'd shield. Screw this together. Okay, now a couple things about the axial. How much do I need to angle on her?
10.
What's the range?
10
Did I
to
say
30.
15 to 30.
15
Yeah.
to 30.
So really, the hypo is going to be
30.
and the hyper is going to be.
10. 15.
So most people just do 20.
Yeah.
Kind of pick a middle range on the average person. Okay, so I need to angle which direction? So watch what happens when I angle cephalic. 2 things. First of all, before you turn the tube, close your eyes, you should bring the tube down because look what happens if you don't. See how now you're going to put the light right in her eyes? So think about bringing the tube down first before you put your angle. Plus, it might be easier for some of you to see this. Okay? When you bring your tube down, what else do I have to pay attention to?
The table.
The table, exactly. Don't let me find you going, the table's in, right? Get the table out of the way.
Do we have to change the SID?
You can keep it at 40 actually. You don't have to bring it in. You know that whole rule of 1 inch for every 5 degrees? We actually measured it on the table one I'll show you, and it didn't seem to really make a difference. So we're just going to leave it at 40. So I'm going to bring the tube down, and then I'm going to go ahead and look. Now, when you look at the angle indicator here, the protractor, it's set at 90. Yeah, thanks. It's set at 90 degrees. So I want 20 degrees. So when I turn the tube up, it's going to go to
110.
110, exactly. So if you want to, a lot of you had trouble like figuring out exactly what angle you thought you were at 5 and you were at 10. Remember, the red line has to be right over that same white line. So let me see here. Okay, so in this case, if I'm going to go to 110, you should see the 105 and the line right after that. But the line that you're centering to is the 110 line. Anybody want to check it? What? Well, past the 105 to the 100, but 105 would be 15 degrees. So depending on how much you're going to angle, you would go from 90 to 105. I'll turn the light on. Now when you center the CR for the clavicle for the axial, no, I'm going to turn the light on. So here's the clavicle. We're all getting punchy on. So you want to make sure that the CR is actually going to go under the clavicle, not at the shaft, mid-shaft, because you're projecting the part up. If you center right on the part when you're angling the tube, you're going to actually miss it here. See that? So you want to go just below it, and then of course you can collimate in tighter. Okay.
You said we do this bilaterally for 10, right? Oh, for
No,
the
that's the
clavicle?
AC you're thinking of. Right now I'm just doing clavicle.
Oops. One from every class thought clavicles were bilateral.
Really? Huh. Well, we're consistent then, aren't we?
What?
But you know, the only place you might see bilateral done is with P, because it's harder to see fractures sometimes, but again, we're not covering P's yet, so. Okay, so this is the axial clavicle, and then I need to do one more thing, and what's that?
No.
Remember to center my cassette and my
Cassette.
light, because I've now put an angle on the tube. Remember before it was set up for perpendicular, so you're gonna, if you're angling up, you have to move your cassette up. Okay? And I do this last because I need to see, because if I start doing this and then centering, like I do this and I'm trying to get this all set up, and then I realize, oh, I'm not in the right place, then I gotta move this and move this.
So deep breath and hold.
No, I'm saying just tell her to stop breathing. If you tell her to take a deep breath, it might cause the anatomy to move out of the light. Okay, so next
So
we'll
the
do,
body is in the right place, or
It's right there. You want to show them
well, yeah, I guess we just have to look at
Yeah. Since you're right there, you
Yeah.
can move your back, move your forward.
Okay, I'm good with that. Okay, so next is the scapula standing, and then I'm going to also show you these positions and laying down. It's fine. 2 inches below
2
the
inches below
coracoid, so
coracoid.
really 2 inches below the clavicle, and then about 1 inch medial to the axilla here.
Like so.
So when you're doing this, try not to wear like blousey shirts with something. I mean, Kat's got a perfect outfit on, but you're probably going to be cold. So not everybody wants to wear that kind of outfit. But like even what she's got on, you've got nice tight sleeves here. Because if you wear it blousey, it's harder to see your armpit. I don't think you want people poking into your armpit too much, right? So 2 reasons. You don't want to put your finger in somebody's armpit. And they're probably pretty ticklish. A lot of people are very sensitive, right? So you want to be careful about that. Okay, so 1 inch medial and 2 inches posterior, inferior to the coracoid. And then what am I going to do with the hand? Bring it up, right?
Bring it up.
That's what this. I pulled really bad. I gotta get the tool down and fix this. Bring it up on the So this brings the scapula parallel to the image receptor now. Okay, a couple more things I need to do.
Align them.
That's done. What else?
Align it.
Boy, they're not synapsing, are
They're
they?
not centered.
I'm centered.
It's centered?
I know. Bring the tube in. Remember, scapula, short SID.
Oh.
Obviously you didn't remember. What this does is it blurs out the anterior ribs, and then it puts the scapula that's close to the IR in better detail, better focus. Okay? So when you bring in the IR, look what happens though. I'm
It's
going to have to
more.
open my collimator back up. Because as you bring the tube in, it's going to make the collimation smaller. You'll see it better when I show you on the sternum in a few minutes as well. Okay, and then what else could I tell her as an instruction before I take my exposure? Slow breathing.
Slow
And
breathing.
I want you to find out at your hospital what they require, because some will do breathing techniques, some won't. Some will
Yeah.
just say take in a
They
deep breath
stop.
and hold it.
They hold it for the ribs too.
Well, they have to hold it for the ribs.
No.
If you're breathing in the ribs, what's going to happen?
Oh, it's
Well,
gonna
the
go.
ribs are moving, right?
Yes.
But I have seen people try to do breathing techniques on ribs, which makes no sense to me at all. But I'll get to some of that craziness later. Okay, so I'm going to now go ahead and relax. So if I was in this, if I was still doing the scapula, what's the next position? Lateral.
Lateral.
Okay, so now we've got the scapular Y for the lateral scapula, which I just showed you 10 minutes ago. Okay? All right. Okay, next position.